Well, good afternoon and welcome to the New York State Department of Health's Commissioners Grand Rounds. Hello, I am Dr. Jim McDonald, the Commissioner of the New York State Department of Health. Today's Grand Rounds is titled Preventing Maternal Mortality Recommendations for Actions. Maternal mortality is a very big public health issue, a big concern of mine, and one that is rife with a lot of solutions that, implementing together, we can make some progress on. Maternal mortality is also heavily influenced by racial and ethnic disparities, and a host of other issues. So it really requires a collective approach, really a comprehensive approach, not just from healthcare, but all avenues of the world we live in today. Our webinar is going to provide an overview of maternal mortality in New York State, address some key initiatives, including the Maternal Mortality Review Board, the Advisory Committee, some of our community engagement efforts, and the Maternal Home Collaborative. So participants will gain actionable strategies to help reduce and hopefully eliminate maternal deaths and explore a model designed to improve maternal health outcomes. We have several speakers today. First, we're going to start with a discussion of the epidemiology with our own Dr. Marilyn Kacica from the New York State Department of Health. She's our medical director for the Division of Family Health at our department here, and she oversees maternal and child health programs. And she addresses some initiatives such as the New York State Perinatal Quality Collaborative and the Maternal Mortality Review Initiative. Next, we're going to have Dr. Mary E. Dalton, who's going to discuss the activities of Maternal Mortality Review Board. Dr. Dalton's an obstetrician and gynecologist, chief and chair at the New York Presbyterian Columbia University Irvine Medical Center, and she specializes in maternal fetal medicine. She focuses on managing high-risk pregnancies and co-chairs the New York State Maternal Mortality Review Board. Following that, we have Cheryl Hunter Grant, who's going to present on the Advisory Council and community engagement efforts. Cheryl Hunter Grant is the vice chair of the New York State Maternal Child Health Block Grant Advisory Council and chair of the New York State Maternal Mortality and Morbidity Advisory Council. She has spent her career addressing health inequities and improving maternal and child health outcomes across New York State. And then towards the end, we're going to have Dr. Wendy Wilcox, who's going to speak about Maternal Home Collaborative. Dr. Wilcox is the Chief Women's Health Officer for New York City Health and Hospitals. She's the co-chair of the New York State Maternal Mortality Review Board and has been a long-time advocate for women's health and maternal health equity. And then after the presentations, we'll do a little bit of time in facilitated panel discussion. And if we have time, we'll address some questions and do a Q&A if we can here. So really glad you're with us today. The next slide, I just want to really just highlight a couple of things. If you have questions, you can email the address on your screen right now, which is grandrounds@health.ny.gov. We'll answer questions as best we're able to. So please feel free to jot that email address down if you'd like to. Just to let you know, we are pleased to be offering continuing medical education today, accredited by the Medical Society of the State of New York. And if you want to receive the CME credits, you must attend the entire live session. The post-test will be displayed on a screen as a QR code after the session concludes. So about 12:56, if you're hanging out with us here, have your iPhone or Android device ready, and you can just get that QR code, answer a few simple questions, and then that continuing medical education CME will come to you through email. So that's a good thing to get there. Just make sure you use the same email address you registered to complete the post-test. We do have a few disclosures, and they're up on the screen for you to look at. That just a few disclosures here for today's discussion. Just reminding you, there's no commercial funding that's been accepted for this activity. All right, now, if you could get your telephone or Android device ready here, we have a simple poll. This is just a little thing. If you just take your camera, point it there, click on the QR code there, and just answer the one question poll, you'll get us off and running in great shape there. All right, super. Having said that, let me turn our time over now to our own Dr. Marilyn Kacica. Dr. Kacica, why don't you take it from here a little bit? Thank you so much.
Thank you, Commissioner. Next slide. So we're going to be talking about maternal mortality, and I am going to begin the presentation on giving you an idea about the population and birth demographics in New York State. We have in New York State, females occupy 51% of the total population, with about 4 million women of childbearing age between 15 and 44 years. We have 209,947 births a year, which is has been decreasing over the last several years. And 96% of those births occur in hospital settings. The majority of births occur between women between the ages of 25 to 34. And when we look at the ratio of white non-Hispanic births to Black non-Hispanic births, it's a ratio of 3.75 to 1. And Hispanic, it's 2.13 to 1. We see that as far as births by primary insurance coverage, that Medicaid covers about 48% of the births, excuse me, and private insurance about 47%, with a few others, with self-pay, Indian Health, or Champus. Next slide. When we look at the rate and the trends in maternal mortality, and these are the trends as reported in vital records. So these are maternal deaths that occur within 6 weeks of the birthing person dying. You see over the last 3 years that the rate has actually increased, and it has increased for the United States, for New York State, and the rest of state, and New York City has stayed about the same. And I think what we're seeing here is the impact of the COVID pandemic. Next slide. When we look at the race and ethnicity of these deaths, we see that in New York State, Black birthing people are 5 times more likely to die within a year of pregnancy than white persons, and that these racial inequities in maternal death in New York State have persisted over the last 20 years, and they have disproportionately burdened Black birthing people. Next slide. I just want to go over some definitions for you so you understand how we define pregnancy-associated deaths. So a pregnancy-associated deaths for all 3 of these categories is the death of a woman during pregnancy or within 1 year of the end of pregnancy. However, if the death is termed pregnancy-related, the death occurs from a pregnancy complication, a chain of events initiated by pregnancy, or the aggravation of an unrelated condition by the physiologic effects of pregnancy, for example, uterine rupture. If the death is pregnancy associated but not related, the death occurred from a cause that was not causally related to the pregnancy. For example, a car accident resulting in a death. And some of the deaths are unable to determine the relatedness. We just don't have enough information, or we can't decide. So, for example, a sudden cardiac arrest with unknown cause in the pregnancy period or postpartum. Next slide. When we look at our pregnancy-related deaths and live births by race and ethnicity in the population, the blue hashtag bars are the proportion of the race ethnicity category of our births. When you look at the blue bars, you can see that the Black non-Hispanic population is overrepresented in our pregnancy-related deaths. Next slide. When we look at the distribution of circumstances surrounding deaths for pregnancy-related deaths, so these are for all deaths, we see that 24% are associated with obesity, mental health conditions, about 11% with substance use disorder, and we found discrimination to be related in 47%. Next slide. So to give you a very high overview of what we're seeing, because there's a lot of detail and we could talk for hours about this. When we look at our rate over the period of 2018 to 2020, it was 18.5 deaths per 100 per thousand live births. When we look at Black non-Hispanic women, they had the highest pregnancy-related mortality ratio among all races, for every education level, for every body mass index level, for both vaginal and cesarean deliveries, and for both Medicaid and private insurance. To give an example of that, a birthing person who is Black and has private insurance has a higher risk of dying than a white birthing person on Medicaid. When we look at higher mortality ratios among women, we see that those aged 40 years or older at the time of death, those who received Medicaid, those who gave birth via cesarean section, and those who lived in New York City had higher mortality ratios. Next slide. When we look at the underlying causes for pregnancy-related deaths, so what caused the death? We're seeing that hemorrhage is the leading cause of death with 19%. Embolism and mental health conditions both comprise about 14.9% of the deaths, followed by cardiomyopathy, infection, and amniotic fluid embolism. Next slide. So where are these deaths occurring? So if we sort of define the state in health service areas, and you can see the numbers associated with the area. So for example, health service area 1 is Western New York, 2 is Finger Lakes, 3 and 4 are Central New York and New York, Pennsylvania. 5 is Northeastern New York, 6 is Mid-Hudson, 7 is New York City, down at the bottom, and 8 is Nassau, Suffolk. Next slide. And when we look at the pregnancy-related mortality rates for these different areas, you can see that New York City has the highest rate of mortality at 25.1 per 1,000 live births, followed by Western New York, the Finger Lakes, Central and New York, Pennsylvania, Mid-Hudson, then Nassau, Suffolk, and Northeast New York has the lowest. So this is sort of where we are seeing the deaths. Next slide. We also want to let you know when are individuals dying in relation to pregnancy. As you can see here, the majority die within 6 weeks of giving birth. So 23% while pregnant, 48.8% within 6 weeks. And then from 43 days to a year, we're seeing an additional 28% of women dying. Next slide. One of the biggest deliberations in the Maternal Mortality Review Board is to say, was this death preventable? Because if it was preventable, we want to make recommendations to intervene in the future to prevent maternal deaths from occurring from the same cause. And we see that overall, about 74% are deemed preventable. And it pretty much is above 70% for each of the different time categories, while pregnant within 42 days and 43 days to 1 year. Next slide. I do want to point out a nuance in the deliberation of preventability. It's really not black and white. And these are very difficult discussions. So when we look at our preventable deaths, the committee will say, was there a good chance that we could have prevented this, or was there some chance? And there is nuance there, but it is a very intense conversation, and they're not all the same. Next slide. Okay, next slide. I mentioned this before, that 47% of all pregnancy-related deaths are said to occur with discrimination, and 60% of Black non-Hispanic pregnancy-related deaths have discrimination described. And the last slide is just going to show you, next slide, that healthcare is a piece of the puzzle when we are looking to solve the issue of maternal mortality, improve maternal health outcomes. When we look at the Maternal Vulnerability Index, which is an index that has about 46 different variables into these different themes, you can see that higher scores indicate higher vulnerability. So when we look at New York State, we actually see that the social determinants of health and the physical environment have the highest vulnerabilities for our birthing people than healthcare. So poverty levels, food insecurity, social support, violent crime, housing, pollution, transportation. So I think that we're a piece of the puzzle, but healthcare cannot solve it all. Next slide. These are resources for you if you want more information. There's a lot of details in this report. Thank you.
Yeah, thank you, Dr. Kacica. Let me turn it over now, if you don't mind, to Dr. Mary Dalton from Columbia. Dr. Dalton, let's take it from there.
Hi, good afternoon, and I'm so pleased to be part of this process this afternoon. Thank you, Commissioner. So the State Maternal Mortality Review Board in New York State started with the enactment of the health law in 2019. And the law requires the board to have at least 15 members, be comprised of multidisciplinary experts who serve and are representative of the racial, ethnic, and socioeconomic diversity of the women and mothers of this state. Members are elected to serve a 3-year period. They meet 2 times a year or as frequently as necessary, determined by the Department of Health to complete a timely case review. We actually meet usually about 6 times a year, so much more than 2 times. Next slide, please. Now, as Dr. Kacica said, complications can occur at any time during pregnancy, during the intrapartum period, or in the postnatal period up to 1 year after delivery. And what state maternal mortality review committees do is they collaborate to better understand the drivers of maternal death, and very importantly, to report on missed opportunities and identification and management of pregnancy-related emergencies in obstetric and non-obstetric settings. So in the next 8 minutes or so, what I want to be able to do is describe our process, describe in particular some of the priority actions we have recommended, and describe the translation of these actions in some examples to show you how we are driving down maternal mortality or some causes of maternal mortality in our state. Could I have the next slide? At the start of every meeting, we talk about our vision, and we say this out loud, that no New York State family or community suffers a loss of a mother due to a preventable pregnancy-associated death. And our mission is to increase awareness and knowledge of the issues surrounding pregnancy-associated deaths, to promote change among individuals, communities, healthcare systems to reduce the number of deaths. Next slide. Now, the goal of the review board is twofold: do a comprehensive review in a timely manner within 2 years of the death, and to identify and prioritize actionable recommendations. Next slide. This is our process. The Department of Health staff identify the cases. The records are abstracted and a case narrative is written. This is then shared with the board member who reviews the case for completeness and prepares a summary for the board. The member reviewer presents to the board, and then the board discusses and makes recommendations for action. Next slide. Now, Marilyn has already talked about some of these discussions, and during these multidisciplinary discussion, we attempt to determine the cause of death, what were the factors leading to death, what was the preventability, and I keep saying this, the opportunities for intervention, that if we could have changed the course of events, how could we use this to prevent further deaths? New slide. Now, the factors contributing to pregnancy-related deaths are sorted into 28 specific factors. Marilyn has mentioned some of them already: discrimination, structural racism, unstable housing. We also focus, however, on clinical skills and quality of care among the individual practitioner, healthcare systems, and birthing facilities. And in addition, then, each factor is categorized into one of 5 levels: community, facility, patient or family, provider, or system. Next slide. Now, these are some of our recommendations. We have mandated equity training for all healthcare workers in birthing facilities. Our aim is to diversify the workforce and make it culturally complete. And this is so important to think about early on in the course, where students and student nurses and midwives are, you are intentionally looking to diversify the workforce. Quality improvement efforts through the New York State Quality Collaborative. Expanding access to care through home visiting and what Dr. Wilcox will talk about, maternal homes. You've seen what Marilyn's data is on the maternal health issues, supporting maternal health, and providing feedback and inclusion to our communities that are so key. Next slide. Now, some of the successes from the New York State Perinatal Quality Collaborative that was established in 2010 and led by the New York State Department of Health. And the Quality Collaborative works to improve maternal and fetal outcomes, and doing this by creating the best, the safest, and the most equitable care in all facilities. Some of the successes show that 97% of births in the state occur in a birthing facility that has participated in a quality collaborative project. 90% of hospitals reported using QBL, quantitative blood loss, by the end of the New York State obstetric hemorrhage. And importantly, and something I'll mention later, is that 5 more times did patients get a pamphlet on education and postpartum eclampsia, and this went from 12.3% to 80% by the end of the maternal hypertension project. New paragraph, new slide. At the recommendation of the board, where we saw patients that were dying from maternal cardiac disease, we recommended that ACOG Safe Motherhood Initiative present a bundle, and this is completed now and is on our website. We also recommended that our ACOG and our College of Emergency Physicians work together with the state to create opportunities for obstetricians and emergency room doctors to collaborate around the best care. There is a webinar that will be coming up to discuss this tool on January 23rd. Next slide. Dr. Kacica mentioned the impact of maternal perinatal mental health. Our clinicians frequently would say, we screen for mental health, but we've nowhere to refer them. Well, Project Teach has really changed that by training clinicians in mental health assessment and psychopharmacology treatment, having availability of clinician-to-clinician phone consultation, and providing linkages to community-based mental health services. Next slide. And then when we saw so many deaths occurring from substance use disorder, we recommended that brochures be developed to describe naloxone, its use in reversal of overdose, what symptoms to watch for, and how to obtain naloxone through the low or no copayment through the New York State naloxone copayment assistance program. This was an extremely collaborative effort with the New York State Perinatal Quality Collaborative, the AIDS Institute, the patient advocates from New York State Opioid Use Disorder in Pregnancy, and the Neonatal Abstinence Syndrome Project. Next slide. And then finally, as a result of all of the collaborative work that we did, NIH recommended that 10 maternal centers of excellence be created nationally to review the scientific evidence around prevention of maternal death and to collaborate with communities. And we were very fortunate here in New York State that we applied as a result of this RFA with the Department of Health, with the Safe Motherhood Initiative in New York, with Health in Hospitals, with the University of Rochester, Columbia, Cornell, Mount Sinai. Pretty much the majority of the major institutions in New York collaborated around this. And to quote what Dr. Diana Bianchi said as director of NICHD, through collaborations with community partners and others, the Maternal Health Research Centers of Excellence will generate critical scientific evidence to help guide clinical care and reduce health disparities during and after pregnancy. And what better transition than to my colleague, Dr. Hunter, who will be speaking about community efforts, which is really the goal of the Maternal Health Center of Excellence.
Well, thank you, Dr. Dalton. I'm excited to be here and tell you a little bit about the work that the Maternal Mortality and Morbidity Advisory Council is engaged in, and even equally importantly, to help you understand what you can do to facilitate change to achieve the goal that we all have. Next slide. Our composition is pretty much, and our origin is pretty much the same as the MMRB. We had the legislation that organized us, and we are a diverse group of experts, including community members and a host of others representing the diverse population here in New York State. And we're really trying to drill down on not only the associated social determinants of health, the environmental issues that are known to impact, but also to address the discrimination and racism that is driving some of the outcomes as we've seen. Next slide. We get information from the MMRB, the data, as well as recommendations, and really try to drill down on that with a racial justice framework that drives all of the work that we do in deliberating our own recommendations. We look at the impact of racism on perinatal health and strive to get at those root causes and systems that are contributing to maternal deaths, because we know it's not just about individual behavior, although personal responsibility is critical. The data reveals that it's the systemic issues that really need to get addressed, that are harder to address, but need to be addressed nonetheless. Next slide. The data, and again, to remind us that we're not just talking about numbers, but individuals, people. The news is replete with stories of these deaths that are occurring here in New York City. The data also told us that about 74% of the pregnancy-related deaths are preventable. With all the caveats that were listed, nonetheless, it gives us opportunity to make change because they're in the space of preventability. Next slide, please. Reminding the cost of the racial discrimination that was discussed. It increases hospital costs. So we want to save lives because that's critical, as well as saving costs to the system if we address head-on the racial discrimination that is contributing to the maternal deaths. Next slide. So the methodology that we use, as we mentioned, using a health equity lens as we review the information we get from the review board, as well as what is known in the community from the members of our council, as well as the data that's available. We also, in our recommendations, wanted to acknowledge that everyone can play a role, and we do call on individuals, institutions, and all to take action in their corner of the world, near and far, to take action. And our report is organized in 3 big domains: policy change, best practices, and new or enhanced strategies. And here's the link to get access to our report. Next slide. But I want to present the information as this call to action to let us know from our recommendations what we can do, what you can do to take action to help start to reverse this trend and improve birth outcomes so that no woman or birthing person dies, especially in those 74% that are potentially preventable. So we've got actions. We recognize that actions need to be taken from a wide range of the partners working together to address those longstanding systemic issues, as well as the individual health issues that we've got. We each have a unique position that we can take and influence change, and to recognize that the voices of the individuals with lived experience is critical. We will not make changes to those systems that are entrenched throughout all of our medical care and our United States if we don't listen and hear what the people impacted by this are saying, so we can have a different lens as we look at the system to then determine how we need to make the changes. Next slide, please. So as we address and recognize and reduce racism and discrimination, we have called for providing annual and ongoing racial equity training for all staff in the agency. And this is also another place where we can spotlight those systemic issues and start to make change. We need to use as a litmus test for the racial analysis things based on Ibram Kendi's How to Be an Anti-Racist, and ask ourselves where we're putting the problem. Is the problem being put on the person, their obesity, their not accessing care, or is the problem being put on the context? And if the problem is being put on the person, then we should interrogate that as a racist idea. And this is important because the discussion around racism and discrimination in this country is difficult. We still haven't recognized it for all that how it impacts on all of what we do in healthcare, as well as those issues affecting healthcare, social determinants of health and the like. So we've got to make sure that we lean into those difficult conversations, collaborate with the health department's Office of Equity and Human Rights, primary healthcare and health systems, to develop racial equity training, as well as having a focus in all of this on supporting patient-centered care and decision-making throughout the birthing experience. And if it's uncomfortable, those conversations lean on into it so we can address change. And also pointing out as we go through these slides, the real people who have died to remind us that we're talking about human beings whose lives are worthy of us leaning into difficult conversations to ensure that we prevent deaths going forward. Next slide. We also need to address this impact of social determinants of health. And again, partnership efforts can help us to address this, become more aware of it, and focus on those structural social determinants of health, working with individuals, one, to understand what the impact is for them individually in community. And while it may be out of our purview as doctors, as nurses, as midwives, we can tap into others in our community to be part of the holistic approach to address this. Next slide, please. We also, as has been mentioned, about the need for support for mental health, and that being one of the variables contributing to the maternal deaths. We utilize the services as been previously mentioned. Another resource, again, in tapping into what's available, the Postpartum Resource Center of New York has excellent resources around perinatal mood disorder and anxiety. And we also have to remember the humanness of all of us in this process. And as facilities, providing families as well as providers the time and space to grieve. All of those deaths are human lives lost. All of the near misses, the maternal morbidity in there, are human lives that impact us and touch our humanity, and we must address that. So not only the mental health of the pregnant women and pregnant people, but also of all of us in this space. Utilizing and tapping into organizations such as the Association of Black Psychologists for healing circles that will allow us to be more effective in our work in making change. Next slide. We also call for us having new partnerships and explore new ways to drive action, to expand our advocacy efforts by creating and leveraging new partnerships. So we don't have to do this alone. Doctors and nurses and midwives and clinicians and hospital systems aren't doing this alone. We're well aware that most of the impact on healthcare happens outside of the hospital walls. So we've got to bring in that same structure, that same community to assist us. And we're also calling for the legislature to advocate to allocate funds for community-based organizations so that they can be at the table for perinatal home visiting programs, medical homes, and perinatal quality improvement projects so that everyone can fully participate in ways we know will make change happen. Next slide. We are also calling for ways to find new partners and to drive action, continue by having community-based organizations lend their voices as well as those with lived experience to affect change, and for us to change the way we process and value and create space at the table so that the voices can be there as we're looking at how we make change and elevating the expert witness of those with lived experience. And finally, we are also calling for action to improve care and coordination to optimize postpartum care, to collaborate again, which is a key theme, collaboration, to provide that care coordination supports throughout the system. And we are so pleased that one of our recommendations has already been enacted with the expansion of Medicaid coverage to include 1 year postpartum. This will allow us to catch and to support and have the resources available for those births that the deaths that were occurring outside, again, from a preventability standpoint, that pregnant woman, the pregnant person, that family won't feel that they can't access healthcare because their coverage has ended. So thank you.
Yeah, thank you so much, Cheryl. That was great. Let's turn it over now to Dr. Wendy Wilcox. Dr. Wilcox, great to see you again. Why don't you take it, Dr. Wilcox?
Thank you so much, Commissioner. So I'm here to talk about the maternal home and the iteration that we have adopted at New York City Health and Hospitals. Just to give a little bit of background, in 2018, New York City Health and Hospitals received funding from City Hall to address the maternal mortality and morbidity crisis. At that time, there were more than 3,000 women experiencing a life-threatening event during childbirth, and about 30 women died each year in New York City. At that time, the ratio was Black non-Hispanic women were 8 times more likely to die in childbirth. Other reasons of why we formed the maternal home. I think you heard that I'm on the Maternal Mortality Review Board. I also sat previously on the New York City Maternal Mortality Review Committee, and I knew a lot of the cases in terms of these factors influencing a lack of continuity of care. Sometimes we don't connect new parents and pregnant people to community supports that can help them. There's often a lack of follow-up in order to ensure that a patient will connect to specialist care. There are social supports needed. There's care coordination and follow-up among providers that can sometimes hinder the appropriate care. Providers not speaking to one another, lack of information transferring, and pregnant patients with chronic conditions are at higher risk for poor pregnancy outcomes and definitely need continuity of care. Next slide, please. These were some recommendations from the Maternal Mortality Review Board, and you'll see after each statement the years when these were recommended. The department should convene a multidisciplinary group of key interested parties to develop standard guidance on implementation of a maternity medical home project that will prioritize people with chronic conditions, and New York State should provide the funding to support a pilot project of the maternity medical home. Those were recommendations in 2018 and 2020, and some of what I spoke about in the last slide, such that hospital systems and OB providers should engage community resources better. not only during the prenatal period, but also on discharge planning for the postpartum period, such as doulas, visiting nurses, community health workers. You can read it. You can see it. I don't need to read it to you. But pregnant people, especially those with chronic conditions and or mental health conditions, need to have continuity of care and the whole team engaging in their care. And so this was a recommendation. That was a recommendation in 2018 and 2019. Next slide, please. So what is the model based on? We based the model on the primary care medical home model that was so popular in the 80s and 90s. And it's very patient-centered. So it definitely supports patients not only throughout their pregnancies, but in the postpartum period. And it helps to coordinate the multiple services necessary to provide this comprehensive care. It aligns with the triple aim. So improving the patient experience, improving the health of populations, and reducing the cost of healthcare. Next slide, please. So we implemented a hospital system-based patient-centered program, which is present at all 11 of our acute care facilities. It provides comprehensive wraparound supports to pregnant people with identified needs in the areas of social determinants of health, behavioral health, or complex clinical needs. If you look around the country, there are pilot programs of maternal homes and examples that focus on one thing or another, such as the prevention of preterm birth, or to help patients with substance abuse. We wanted to widen that umbrella and serve as a catch-all for pregnant people with needs in all of these areas. We don't require any specific insurances. We cover everyone like we do throughout health and hospitals. And our maternal home team members are licensed social workers and care coordinators. Those would be our non-licensed people. And they work alongside the clinical teams. They are present actually in our clinics, in our practices, to provide supplemental care across our system. Next slide, please. You can see here, patients can enter at any point during their pregnancy. The maternal home team member will do motivational interviewing. They will be assigned a risk tier. There's care coordination through the team members for all needed services. We've created standardized care pathways, especially for common risk factors for poor birth outcomes. And they engage in shared decision-making with the patient, such as developing birth plans. Next slide, please. This is an example of Tier 1 services, which is the most basic level. They will perform certain standardized questionnaires and assess for socioeconomic needs and make all the appropriate referrals to community-based organizations. They will assign a risk tier. They will help in birth planning. And most importantly, they will give a warm handoff to our pediatricians. Next slide, please. This is an example of our risk tiering. So I just described previously the most basic tier, Tier 1. Tier 2 is elevated risk. So if patients need help with obtaining housing, or they have intimate partner violence, they may have some other medical complications that need them to access our very complex system more often, or they may need to go seek other specialists such as internal medicine, cardiology. Our maternal home team members are there to help patients navigate the system, as well as get tied into community supports to help them throughout their pregnancy and beyond. The highest risk, which is Tier 3, also engages more screening tools. So in Tier 1, it may be, these are the least amount of times someone would need to be seen. So for Tier 1, it could be just one visit with the maternal home team, and then they can contact the team member if they want to come back. For Tier 2, it's definitely once a trimester. Tier 3 is at least once a month, if not more frequently. I will add that our team members have cell phones. Patients can contact them. They can text them. They often call if they have missed an appointment or have difficulty accessing other services, and they can be in constant contact with the patients, which the patients really enjoy and like. Next slide, please. These are some highlights, and I'll just say You've heard about where we started. The pilot project was at Kings County in 2019. During the COVID peak, that was when we really were just getting going. And it was interesting because our maternal home team members really did help, especially in making sure that our patients who were discharged with COVID had appropriate follow-up and were okay. They were doing check-ins. In July of 2023, we partnered with our insurance plan, Metro Plus. They have a high-risk team, and so instead of duplicating services, we've coordinated with them, and it is really helpful, such as if a patient needs a durable medical equipment or like a blood pressure cuff, they can be very helpful with that. And then really exciting is that we have 2 independent analyses going on right now about the program, because there is an indication that patients do have better clinical outcomes and are getting more cost-effective care. Next slide, please. You can see the data here in terms of it's mostly African-American and Latina patients being served. The most common age range is 25 to 34. And then the top high-risk socioeconomic referrals, and then the top healthcare referrals on the bottom. Next slide, please. So far, this is 4 years worth of data in terms of patients enrolled, referrals made, and all referrals are almost 30,000. The ones made to behavioral health are extremely important as well. Next slide, please. What did we learn? That really embedding it within our clinical space allows not only face-to-face interactions and having the patients feel more comfortable with the maternal home team members, but they can easily access the clinical team and become members of the team more easily, so that there's, bilateral communication. They help to facilitate referrals in-house. As I'm sure you know, every hospital is different, so they sometimes, need to know those nuances. And within their communities, they get to know the resources within their own communities, and then they share it so that if something is lacking in another neighborhood, the maternal home team member from the other neighborhood knows that they can refer to the maternal home in the neighborhood where the service is offered. And as I said, they give a warm handoff to peds. Next slide, please. This is our next iteration. So we've realized that these can be modular. So this is a version of a maternal home for cardiovascular conditions during pregnancy, and we are piloting at Kings County with funding from the Robin Hood Foundation. It will get started in March of 25. Next slide, please. Thank you.
Thank you, Dr. Wilcox. That was great. So, now we're at that point. We're going to have our little facilitated panel discussion. If you do have questions, you can email us at groundrounds@health.ny.gov. But I'd like to dive into the first question, if it's all the same to folks here. And then we go right to Dr. Dalton, if you don't mind. So through your work with the Maternal Mortality Review Board and your role in managing high-risk pregnancies, can you share one significant success or win that has positively impacted maternal health outcomes? Dr. Dalton, you want to address that, please? There you are, Dr. Dalton. Great.
Sorry about that. I apologize. Thank you for this question. And I would say one example here in New York State is the dramatic decline in deaths from maternal hypertension. And if you look at the national data on deaths due to hypertension, I just put it in front of me here, and between 2006 and 2010, 9% of deaths were due to hypertensive disorders. And in 2024, data from 2020 from 38 maternal mortality review committees was 7.1%. Okay, listen to New York State. Published in 2016, our data in New York State from 2006 to 2008, 23% of pregnancy-related deaths were due to hypertensive disorders. Most recently, they were present in such small numbers that it was suppressed from the data and noted as small size. So how did this happen, this dramatic reduction? It occurred because of efforts from the Perinatal Quality Collaborative, led by the Department of Health, where they had a project on training and awareness of hypertension in all birthing facilities. Additionally, the Safe Motherhood Initiative did a bundle on hypertension and standardized treatments, standardized risk assessment and treatments, published that in 2013, and it's available on an app and is most recently updated. So that intensive collaboration with the Department of Health and its partners with ACOG and all of us practicing in birthing facilities across the state, where the majority are involved in the hypertension project, has led to a dramatic reduction in maternal hypertension deaths. So for me, this gives me enormous hope, because we identified a preventable maternal death. We identified an action taken that could be introduced globally across the state. And everyone took notice. Families took notice. Communities took notice. Healthcare facilities took notice. And we have had a dramatic reduction. So we need to make that stick. And we need other stories like that, like in hemorrhage and mental health, and hopefully we'll have that. But to me, that's the best example. Dr. McDonald, thank you for the question.
Yeah, no, Dr. Dalton, that was a great example. And, it's interesting. I think when you talk about collaboration across the state this big,
yeah,
then it's not easy. It just, and really it's how do you get everybody the same information at the same time, yet apply it to their unique situation? Because New York's a pretty big state, and I sometimes think of ourselves as the United States of New York. We're a pretty diverse state and a lot of different settings there. So, I think it's a great example. Let's go to the next question. Cheryl Hunter Grant, I wonder if I could ask you this question, if you don't mind. How do we ensure that community engagement is effectively integrated into maternal health programs? Cheryl, any thoughts on that one?
Yeah, the first thing is to make that commitment to it, and then think about how we engage differently than we engage inside our hospital walls or our medical practice walls, and create the space for community to be at the table, to one, fully engage them in the conversation, fully work through some of the things that may be automatic pushbacks with HIPAA and the like, to find ways that they can be at the table and have the dialogue and value the voice. Everyone at the community level, from community organizations and others, may not have the MDs, the PhDs, but they have doctorate degrees in the areas that are important to bring to the mix to make the change. We've got examples of it with some of the systems through the maternal medical home, as well as some of the other projects where the home visiting and the like, that we can engage the community and utilize perinatal networks that are still existent throughout the state, as well as the perinatal infant community health collaboratives, where we've got community organizations that have brought partners in the community together to address this issue and have the open dialogue. The dialogue is what's going to make the change happen, and be receptive and willing to hear perspectives that may be different, and ways of doing the work may be different. The other thing that we know, individuals impacted, communities impacted, typically understand and know what things need to get done. So if we couple that with the medical knowledge that the healthcare providers have and the hospital systems have, with what is on the ground knowledge that sometimes takes us 5-10 years for the data to get caught up with real time, and bring folks to the table and understand and hear what they're saying are the issues, and find ways to take action, we can make change happen quickly.
Yeah, thank you, Cheryl. That was wonderful. That was great. Let's go on to the next question. Dr. Wilcox, if I could ask you this, what are challenges to implementing a systemic changes to reduce maternal mortality and morbidity? Dr. Wilcox, any thoughts on that one?
Thank you, Dr. McDonald. So many of the challenges are really getting everyone on the same team to say we are, or to agree and say we are going to do this. And so we definitely get our, I would say, our marching orders from many leaders, such as Governor Hochul, right? Being able to really wanting to improve prenatal health and, for example, offering paid time off to seek prenatal care. And that is something that then we have to get the messaging out, not only to all of the providers across the state and those who work with us, but to the patients. So it's really getting information to everyone who needs it. I will say, when engaged in a study of several programs that were similar to the maternal home, is convening by the Robin Hood Foundation. They were looking at what works. What works is having people whose task is to direct patients and to the care that they need. So when, those of us who are providers know that in a 20-minute visit, it's not always able for the provider to be able to give the patient not only clinical information, but information on what services they can access and need. But certainly if you have people who are, that is their role, they can definitely direct patients to the services, et cetera. And so, and also engaging, you heard Dr. Dalton talk about the dramatic decrease in hypertensive disorders in pregnancy and deaths due to that. A lot of that was engaging our colleagues, not just in the obstetrical community, but in the emergency department community, as well as our nursing colleagues, et cetera. So it's recognizing that we are all in this challenge together and getting us all to row in the same direction with some clear steps.
Yeah, thanks, Dr. Wilcox. I just want, I really appreciate Mike putting up this slide so you can get the QR code. You do have to answer, I think, 3 questions or so. I'll get to that in just a minute, but I want to ask another question of you, Dr. Wilcox. It's interesting. We had a lot of questions that came in, and I'm not going to get to all of them. I'm going to try, but, the state of the state occurred just a couple of days ago. One of the things Governor Hochul talked about, which I thought was really novel, you mentioned that we're the first state in the country to do paid prenatal leave, which, everybody starts with 20 hours. You don't need to accrue it. It's there. But now there's a proposal that we provide $100 per month benefit during pregnancy, an additional $1,200 payment at birth for New Yorkers who receive public assistance. So the way this proposal would work, keep in mind, it's a proposal, it'll have to be approved by the legislature, is if someone's on public assistance, they get $100 per month. At the end of pregnancy, they get an additional $1,200. Do you think that would help? What are your thoughts on that? I mean, it's a different approach. I'd love to know what you think about that.
Yes, there is research and there are examples across the country where that has absolutely improved outcomes and reduced maternal mortality. And that will be helpful. It's really interesting. We're starting to have research that shows that stress in pregnancy can be manifested in many ways clinically, hypertension not being the least of that. And so when patients can go and get what they need, and that certainly will help them to be able to access what they personally need, we will see better outcomes because they will not have those other stresses, which we know can absolutely affect their outcome. There's a lot of data also around, period poverty and diapers. And there's been documented research showing that when people have those items that they need, there are decreased rates of depression and stress. And so knowing that the money that will be given or that is proposed to be given will be able to be accessed by those most at need, that I know will go a long way toward improving improving outcomes from
It's interesting. You touched on another one of the state proposals, which is a partnership with Baby to Baby, where after you have your baby, you get mailed a gift box, if you will, that includes diapers and other necessities. And it's a really interesting approach. It's interesting in America, we don't approach healthcare the same way as other countries do. And it's far too transactional from our liking. And I do think addressing some of these issues are so critical. And I think back to our time coming to a close, my friends, but one of the things I remember you really bringing up, Cheryl Hunter Grant, was this is such important to really focus on improving individual social determinants of health. And that's something we're really trying to do at the Department of Health through our 1115 amendment. And Dr. Dalton, I just appreciate the way you really summarized that perinatal quality collaborative and all the interventions that are going on. There's a collaborative effort, a lot of work we need to do. And Dr. Kacica, I really appreciate it. We just talked about the difference between the pregnancy-related death and a pregnancy-associated death, and just us understanding the epidemiology. And we have work to do in this space, which is great. And it really was fun to have everybody gathered together, to me, on such a critical topic. And I think as a country like ours, we should be able to really get ahead of this issue. And as a state like ours, I really look forward to seeing progress in the future. With that, I thank everyone so much for joining us for our Commissioner Grand Rounds on preventing maternal mortality recommendations and solutions. Thank you so much. I hope everybody enjoys the rest of their day. Don't forget to answer the questions. I do want you to get that CME. It's free CME, something that we want to do here. Go answer that, fill in a couple questions, and we'll get that in the email to you. Everybody have a great rest of your day. Thank you so much. Bye-bye.